Dr. Rosario Columbo is a specialist in cardiovascular disease as well as internal medicine with Jackson Memorial. He's going to be talking to us today about the latest on atrial fibrillation, also known as AFib. He's giving sort of a 2019 update. Thanks so much for joining us.
No, thanks for having me.
So first of all, for people who are just wondering, you hear it a lot, I think sometimes in pharmaceutical ads generally,
Yes.
talking about AFib or living with AFib. What is that?
So AFib is a term for arrhythmia of the heart. Mm-hmm. So what is an arrhythmia of the heart? It's an irregular heartbeat where the conduction system of the heart is behaving abnormally. Instead of having a regular rhythm, it becomes chaotic and irregular. You can actually have very fast heart rhythms and very slow heart rhythms as a consequence of this. AFib can strike many people. It's actually calculated to be as much as 2 to 3 million people in the United States, and it continues to increase in prevalence. And it can affect many different people for various reasons. People with high blood pressure, diabetes, or other heart conditions like heart failure or coronary artery disease. The biggest problem with atrial fibrillation is not just the fact that your heart can change in speed, slow or fast, but actually that it predisposes you to develop clots within the heart.
Okay.
And that clot can be very dangerous because from the heart it can go to the brain, and that causes stroke.
Okay.
And that's the major morbidity that is associated with AFib.
So that's sort of the biggest danger. I mean, it sounds like it's actually quite common.
Yes.
So, and you said it can be associated with things like diabetes. Are there different causes then?
Yeah, so AFib can have a multitude of causes. So many times it presents alone in an otherwise healthy patient, but other times it's someone who's had hypertension or high blood pressure for many years. And the years of, let's say, poorly controlled blood pressure changes the anatomy of the heart and predisposes you to develop this abnormality of the conduction system that's leading to atrial fibrillation. Other things like valvular heart disease can lead to this, other drug abuse, certain infections of the heart, and other types of congenital heart disease may predispose you to developing atrial fibrillation. So there's a multitude, quite a list.
And then when we talk about the consequences of it, obviously it's something that you want to identify.
Correct.
What's the latest in terms of diagnosis?
For atrial fibrillation, it's commonly diagnosed either by listening to the patient's heart, imagine that, putting a stethoscope, you hear an irregular heartbeat, and it's confirmed by doing an EKG or some sort of monitoring of the heart. So an EKG would actually detect the irregular rhythm and you can make a diagnosis right there. Sometimes people have it diagnosed on a monitor that they take home with them based on the fact that they had symptoms of palpitations or something that was unclear, but they were able to diagnose it based on that monitor.
So diagnosis then is pretty straightforward, and then the next step is treatment.
Yes, so once the AFib is identified, which sometimes is tricky, sometimes we actually have to have people have a monitor placed under the skin for a prolonged period of time to try to detect if they have AFib. Those are for patients that actually maybe had a stroke that we couldn't figure out why. They didn't have AFib at the time, but they've been having it. That's actually one of the new updates in the guidelines that this monitoring device called a loop recorder is recommended for patients who have a stroke of otherwise unknown etiology. The treatment then would be various certain medications geared towards controlling the heart rate and also trying to prevent your risk of stroke based on having AFib.
And how is that changing right now?
So the risk stratification is similar to what it has been in the past. Once you have AFib, you already have a slightly higher risk than the general person who doesn't have AFib for developing stroke. By identifying other features such as high blood pressure, heart failure, having a prior stroke or mini stroke. Actually, the female gender has been identified as a risk modifier, but by itself is not a higher risk for stroke. And identifying those features, we've actually been using a score called the CHADS-VASc score, which is helpful to decide which patients with AFib benefit the most from being on a blood thinning agent.
Okay, so blood thinner is not necessarily always the treatment then?
So it depends on your risk profile. So if you're a young, healthy person that has none of those things in that score I mentioned, you may actually not necessarily be recommended to be on a blood thinner, or at the very least an aspirin, 81 milligrams, which is the minimal amount of blood thinning. Patients who have a higher score on that risk profile, then they would be recommended to be on a stronger, what we call anticoagulant. Of which we used to use warfarin, which is a very old medication that we're all familiar with, but there's now, as part of the guidelines, a recommendation to use the newer oral anticoagulants, as they're called, in preference to warfarin in many patients.
So with these new guidelines and also new ways of kind of profiling people's risk, is the prognosis generally better? Are the outcomes more positive?
So yeah, once it's promptly identified and started appropriate treatment, outcomes are better. You do reduce the risk of thromboembolism or stroke, especially if you have a higher risk by placing the patients on the proper treatment. What's important is you also have to have a good conversation with the patient, telling them about the risk of the stroke and embolism that they could get from this, but also discussing the effects of those blood thinners.
Okay.
Because as we know with Coumadin and other things that thin your blood, there's a risk of bleeding, and we have to kind of weigh the risks and benefits with the patient and giving them all the information so they can make an informed decision about the best treatment.
Are there surgical options for treatment, or is it generally
That's a good question. So there's actually some interventional techniques now. There's catheter ablation, where we actually do a kind of a cardiac catheterization, where we go into the heart and we isolate the area that the AFib is originating from. Typically is better in patients once they've been initially diagnosed with AFib, because the longer you've had AFib, the more difficult it is for you to be taken out of it, because it restructures the way the heart anatomy is. And it just becomes a more technically difficult procedure. But the guidelines now actually recommend the use of catheter ablation in someone who's an experienced operator. And the most recent update is in patients with heart failure and AFib. There's actually been shown to reduce mortality and hospitalizations with use of catheter ablation.
Okay, so that's really good news.
Yeah.
How much does lifestyle play into the treatment after this diagnosis happens?
Another good question. So as part of the update, obviously we're trying to control all the risk factors, so controlling high blood pressure, diabetes, and that requires you to be living an active lifestyle with good diet. There's also an update about obesity. There is an association with being overweight or obese with atrial fibrillation, and there's been shown to be some improvement in overall lifestyle and quality of life with AFib if you are in a structured weight loss program. So as the general rule of cardiology goes, taking care of yourself, being active, getting off the couch, and watching your diet, trying to get more leafy green vegetables, fruits, and less of the red meats and stuff. That is always going to be for the benefit of with that heart failure or that atrial fibrillation.
When we talk about lifestyle, it's eating healthy and just moving. And I think sometimes people get deterred when they think, oh, I need to be a fitness guru or something. It's almost that sometimes people look at those changes as being really massive, but it really is just a matter of start going for a walk in the evening and walk for 20 minutes, right?
It's true. I mean, the guidelines recommend at least 30 minutes walking 3 to 4 times a week.
Right.
That's the start, and that's really not that hard. It's just getting that routine down, which is difficult if you're, not the most active person.
All right,
we try to encourage them.
Dr. Columbo, thank you so much. Again, this is Dr. Columbo from Jackson Memorial talking about AFib, and it sounds like with all of the changes that are kind of happening and new interventions, the outcome is more positive.
Yes, definitely.
All right, thank you.
Thank you. It's a pleasure.